Dear colleagues, dear friends, it's my distinguished pleasure to welcome you to this live webinar. With me, I have also live here in this webinar two experts in the field of interventional cardiology. I welcome also the team from Bad Krotzingen, which is Dr. Kamis Mashayeki and Marek Ferenc. Hello to Bad Krotzingen, and I'm very glad and delighted to have these two guys in this kind of seminar, although we have some difficult times due to COVID-19 pandemic. Well, just to introduce you shortly and to present you the agenda of today. These are the disclaimers, and just want to give you a short overview of this live webinar. We have some introduction words and objective to this webinars. Then we are delighted to see a very exciting case from the University Heart Center, Freiburg Bad Krotzingen, and I will give you category data overview of the newest results of the trial, and after that we will have a Q&A and some closing remarks. Well, coming to the objective of this day, we want to show you how complex PCI operators plan and perform a complex calcified coronary case using IVL, the intravascular lithotripsy, which was shortly introduced. We want to understand the mechanism of action of IVL based on the latest OCT evidence. And in the end of the webinar, we will have a review from the latest results of this CAD3 clinical trial. Well, there is no doubt that coronary calcification impacts PCI. It can impair device delivery and crossing, and it can result also in kind of delamination of the polymer of the drug eluting stents. Of course, this can alter drug delivery and have some other impacts. Of course, we know that calcification is responsible also for underexpansion, and the balloons we have in our cath lab often have insufficient force to crack calcified lesion. And finally, the current technologies are limited in respect with their ability to treat calcium, like the debulking devices, which is rod ablation, or the orbital atherectomy. So we have this kind of wire bias, and of course we can also result in some unpredictable complication if you think about the laser treatment. Well, this is the intravascular lithotripsy, and it was introduced to modify the calcium with a balloon catheter and the generator. And if you can run my video, the generator produces energy which are applied by the emitters. You can see in the balloon catheter, and a small electrical discharge at the emitters vaporize the fluid within the balloon to create rapidly expanding bubble, and then this bubble will generate some bubbles and waves, and then these waves create microfractures in the calcium so that the vessel gets compliant and the stent can deliver adequately. And these are some OCT pictures now. If I can have my next slide. Yes, these are OCT pictures after lithotripsy showing nice microfractures. You can see that very nicely in the mid panel at 3 o'clock and 6 o'clock. And this is very effective. And if you go for the stent implantation, you can see that you have a nice lumen gain after your stent implantation. So, and I think now we are ready to have now our live case, and I'm delighted to have this wonderful colleagues and experts in this field here in this webinar. And I just want to hand over now to Kamis Mashayeki and Marek Ferenc, and welcome again to this webinars, guys, and the stage is yours. Well, just we have to unmute the cath lab in Bad Krotzing, and in the meanwhile, well, I can just give you the short note that we have also some polls
Holger,
on
can
the
you hear me now?
website, and you can, of course, ask a question, and we want to address them. So, Marek, please.
Holger, can you hear me now?
Yes, perfect.
Okay, thank you. So very warm welcome to you, dear colleagues from the cath lab #1 in Bad Krotzing. So we are here with very new, working with very new system, Siemens Icono, and with me is Kambis Mashaeki. He will perform this case. I will assist him and lead the conversation with you. And we have as well here Dr. Löffelhardt, who is responsible here for imaging, and we have Sarah and Anya, two wonderful technicians. So may I switch now to the case presentation because of time. So we pre-selected now the patients here, and thank you for participants here. We have here patients with severe calcified and especially calcified and eccentric LAD stenosis, and we plan here to perform optimal lesion preparation using IVL. Next slide. So here, the patient is 80 years old. For a few weeks, he has a progressive angina. This is a clinical point of view. So he is because of symptoms. He has a known calcified 3-vessel coronary disease, and in November, a few weeks back, Kambis performed a complex PCI of the right coronary artery with rotablation, and we saw in this patient a lot of calcium. It was clear the next step will be even more difficult. And at the moment, patient has normal LV function. The creatinine is 0.8, and as you can see, SARS-CoV-2 test negative. So risk factors, cholesterol is high, but now under control with statin therapy and hypertension. Next slide. And coronary angiogram you will see as next step. Next slide, please. So you see on the left, this is a native right coronary artery, and on the right, on the left picture, you see there is a huge calcification in the distal part involving the bifurcation. Next slide. So it was really tough and difficult to manage this case. So there was a need to perform rotablator, to use rotablator as a lesion preparation. Finally, very nice, successful PCI with tap stenting and the bifurcation area. And maybe you can recognize here coils. So it was due to resistance, it was even very difficult to place the wire. There was some small perforation in the small side branch. Okay, but we could manage this with coiling. Next slide, please. So, and if you take a look to the left coronary system, you see huge calcification in the projection to the LAD, and in cranial projection, you see there's eccentric significant LAD stenosis and proximal part of view. Next slide. And so it was, Kambis, you could measure FFR. It was clearly significant. So we saw eccentric plaque distribution. And now, next slide. Now we plan, this is our target today, our goal today, we plan to treat this severely calcified eccentric proximal LAD stenosis. Okay, next slide. So we have 7 French axis, XB 3.5, radial approach imaging. We have here OCT to understand the plaque anatomy, to understand the diameter, the lesion length, etc. Then we use IVL for optimal lesion preparation in this eccentric calcified LAD segment. And then again, we control our result after IVL with OCT, then implant the stent, and finally, again, evaluation due to OCT, and if needed, post-dilatation. next slide. So from our part, from the cath lab, this is just a slide with learning objectives. So first of all, we have we would like to show you how to learn when and how to implement IVL during PCI in calcified lesions, then to demonstrate how to prepare eccentric calcified lesion using IVL as in live setting, and to understand when and how to implement the imaging during complex PCI. I think in this special situation, it's really very useful to have imaging data. And finally, to discuss the role of stent pre-selection for implantation in calcified lesions. So if we have stents with very strong radial forces and with less radial forces. So the question is, which stent should we pre-select in such lesion subsets? Okay, thank you. So we go now to the live picture. Cambis, first of all, you checked the right coronary artery, and the right coronary artery is showing here. You see wonderful result after few weeks later post PCI. Everything is very nicely stable right coronary artery, and this is now picture of the LAD. And we have eccentric, as we know from last attempt, significant proximal LAD stenosis, and there is a stent in the second bifurcation with a second diagonal branch. There is stent which was implanted a few years back, and the LAD distally was attempted twice, but not successfully. So today our plan is to go with IVL and stenting for proximal LAD. You see now.
Should we just, Holger, is there any question from your side at the moment regarding strategy or also for the case?
Well, thank you very much for this very exciting case, and I think very that we have many questions which can be addressed by this nice case, which you selected very well. First of all, just to give us a short overview about your setting, you have used now a 6 French catheter.
With 7, Holger. We're with 7.
7 French. Okay, why do we choose 7 French and not 6?
Well, it's a very calcified lesion. We were not sure if we can have a good plaque modification in case to use a 175 burr. So we just said, and from the last time I had also 7 French, it's a very big artery, and we have maximal backup support. It's a big male, so I think it's okay to go for 7.
Okay, that's a good one.
To have more comfort.
Definitely, if you point out regarding the use of IVL, 6 French will be also suitable. Definitely,
yeah, will be suitable, right?
Yeah. So we are now ready to show OCT pictures.
But Holger, yeah.
Holger, do you have any questions?
Well, there are already some questions on the chat, and the question is, why do you choose the IVL strategy upfront now? And what was the arguments against or the ablation, for example? Can you give us some of your thoughts?
Yeah, I think for that we have to understand imaging, right? So, and probably we can show the OCT pullback. And we will show the pullback to you now. Can we this OCT have? Can we have the OCT, please, Sarah? Thank you. So Dr. Löffelhardt will go to the distal part where we started and then we just go with the OCT. Can you go back? Also einfach durchlaufen lassen vom proximal.
Yeah, okay.
Okay, so this is about in the mid part of the LAD proximal part, and now we go back and. We have here some, as you can see, some narrowing and eccentric exulcerated plaque. And here we see an area where we have also a huge plaque burden, calcified plaque here. And and this is very eccentric here. So we measured already the MSA, and what we found out actually was 2.5. So this is the first problem where we have to understand that probably with 2.0 to 1.5, maybe the burr is not so efficient as we like. And as you know, in eccentric lesions, sometimes we have also a wire bias. So therefore, the question is: are we really doing a great modification with rotablation here? And yeah, Mark,
Candice,
or
definitely.
Holger?
We discussed this point, and if you go here, even with 2.0 burr, we could maybe partially ablate the plaque, but not sufficient. So it's our experience. So now, what is the next point? How can we make this huge calcified plaques, which is indeed deeper than 0.5 millimeters partially. So how can we make it softer? How can we correct this huge plaque? And the only option, how we can do this safe for the patients without a high risk for perforation.
Absolutely.
I think this is definitely IVL, and that's why we choose this.
I mean, Marek and Holger, we have to say actually that at the moment we have no clear answer for eccentric plaque modification. But as you have probably want to say something about your data regarding the sub-analysis of Disrupt 1 and 2, regarding the impact of IVL in eccentric plaque modification, and Holger, maybe you might want to comment on that.
That's a good argument, of course, because we have seen from the sub-analysis of CAD1 and CAD2 data that we can also tackle the eccentric lesion very well with the lithotripsy. Well, if I look at the specific morphology of the plaque, so the question is, do we think that this kind of calcified nodules are also a good target for lithotripsy as well?
Well, that's a good question, Holger. So actually here we see what Dr. Löffler showed us. If we go a little bit back here, a little bit proximal, you see 180 degree here. Ein bisschen nach distal. Here, yeah, actually you can see 180 degree of calcium there, and also thickness of calcium. So maybe we can try to disrupt here a little bit, really the calcified plaque there. And if not, I mean, this is from the OCT subgroup analysis from Carlo Di Mario as well, that in 38% he has seen actually a disruption of calcification at these eccentric plaques. So maybe we won't see and calcify a disruption, but somehow it's modifying also the plaque. So this is actually what we have at the moment from the data, and we'll see how the stand is possible to expand. I mean, the other we have no really good other options, right, Marek?
Okay. So well, I can ask you to start with the case.
Because
we run out of time, but just another question while you are bringing the catheter down there. Do you think that the lesion is very long, and which size of balloon you will choose?
Holger, we can do this now direct with we can go direct with the placement of IVL balloon catheter, but normally I would recommend, we have now very clear OCT data. We know, okay, we can go here upfront with direct with IVL, but normally I would definitely recommend to you to use it to make a channel of a minimum 2.0 millimeters. So what you can do safe in your cath lab in daily routine, take 2.0 non-compliant balloon, go up to 8 or maybe 10 atmospheres, make a channel, don't risk too much.
Können wir das Live-Bild sehen?
Don't use how high pressure, because otherwise you could provoke dissection. And what this method is very elegant method to avoid dissection and to avoid slow flow situations. This is something.
Okay, now you have introduced already the balloon, so just explain us how to use the balloon and what are the next steps.
So the use is very, very simple. We are now in the position. You go now up
It's already
to
cracked.
4
Can you see,
atmospheres. You
Marek?
go up to 4 atmospheres and press the button for 10 seconds. So you can here with one catheter, you can give maximum 80 shocks. So you go, Cambis is going now a bit more
If
back,
you can see,
because we have a long calcified lesion. So we want to do this partially, so twice a minimum.
can you see this, Mark?
Yeah.
This is the first lesion actually, which is a concentric plaque. And after the first shock application, it's already open with 4 atmospheres,
nice.
right?
Thank you. Yeah, that's very,
so
very nice.
So, and we don't need more. And then we use the rest of the 70 shocks for the eccentric calcification.
So
Agreed?
we go now a bit back, and now we will use all these possible shocks
so normally
to prepare the
we
lesion
have,
perfectly.
So normally the company told us that we have to give 2 cycles of 10 pulses each for one segment. So now you only used 10 pulses. This was why, because
that's correct. It will be better to do this twice, but let it in position.
Yeah. I will go just.
No, don't go. Twice per segment. So we go now second time for the same balloon position now, and we still will have 5 shots more. So it's 10 seconds, go to 6.
Yeah.
And that's it.
It's already a little modification.
The balloon is working, so we see some improvement. According to the balloon size, so we should use IVL balloon in setting 1:1, in ratio 1:1. So same diameter like the vessel. So Cambis, we should repeat this here probably a few times in this position.
Now look here, it's even the better precision. I did a little bit pullback, Mark, in the meanwhile. Look, because this is even where we have, can you see at the moment? This was the first application. This was the second. I will just make one video. So there is some reduction of the duct boning there.
So we go in this position. We go with
second time.
Yeah.
We go with a second time.
I agree totally. I agree completely that there's a nice effect of the lithotripsy again, even after 20 pulses. So the question our audience have is, how do you decide to give a certain number of pulses? So do you give always the same number, or 80 pulses, or do you say after 40 pulses the calcium is cracked, so now I stopped? So what is your decision to give a certain number of pulses?
So I think if you have to treat a very long calcified lesion, long segment, so you should give at least 20 pulses, 20 pulses per lesion segment, and then you go ahead. If you don't open, then you have to stay longer until you crack the lesion. And
look here, it's already very well expanded.
Is now, as you can see here, in proximal LAD, and for that we have to spend majority of our possible energy.
So regarding the size of the IVL balloon, regarding size of the IVL balloon, do you go for a 1:1 balloon artery ratio, or what is your selection?
As I mentioned before, balloon size should be in ratio 1:1. So 3.5 vessel, so you should take 3.5 Shockwave balloon, and this is like we just do. So we have now completed the IVL treatment. The question is now to go direct with a stent to perform predilatation with non-compliant balloon. I think what we can do now, first of all, is to do again
imaging,
OCT
right?
imaging,
Yes, absolutely
to see
agree.
what we achieved. And then definitely I would go with balloon, with non-compliant balloon, and predilate the lesion here in this case with 3.0 non-compliant balloon. And the next step, I would go then with stent.
Perfect. During the acquisition of the OCT, maybe the question, which is also asked by our audience, in which sizes the balloon comes from the Shockwave medical company?
Yeah, we have now 2.5 balloons, 3.0, 3.5, and 4.0. So the size is from 2.5 to 4.0, and the balloon length is 12 millimeters at the moment. But what we know, company is working now in some different settings. So they want to do bigger balloons for larger osteal lesions, and even maybe longer balloons to achieve better treatment for long calcified segments. So this will be in the future available. So we do now OCT again, and you can see live how it looks. Incompletes, genau.
Sorry, Nico. Okay.
So you will see now again OCT live, how it looks after IVL. Your writing position perfect. Okay.
Okay.
So we can go. Go. So what we want to see here, maybe we can see the entrance of shockwave energy to the segments, to the
there's some
especially
disruption.
in proximal part.
Disruption there.
Yeah, you can see nicely that 12 o'clock, 8 o'clock here.
Yeah, there's a dissection from the balloon. Great. So also some disruption. Yeah, here you see. Can you stop, Nico, just to show back. When you go a little bit back, a little bit more even.
Here you can
see the cracks.
Yeah, wonderful to see 3 or 4 cracks. Yeah,
this is very
nice. Exactly.
Yeah,
this is classic picture. Okay, so we remove now.
When we go back a little bit, Nico will show probably the proximal part, hopefully.
Können wir 3.0 haben?
Quantum.
Quantum oder Akkuforce 3.020 Akkuforce.
So this is another question I have.
Kopfkissen, ja, machen wir.
Kind of lesion. So do you, after IVL or post-IVL, do you use always a postil, and which size you would go for a postil?
For post-dilatation, right? So I recommend you to do this, even if I rotablate with 2.0 burr. I always use non-compliant balloon to see how it looks.
Holger,
if you implant.
I think it's a good way what Marek is telling, but sometimes if it's only one lesion, and you definitely have seen that you cracked it, I think you can also go directly with the stent. But here it's diffused, calcified, and I think therefore it really makes sense to make a predilatation as well.
What you can see now, it's a 3.0 balloon with 16 atmospheres now even less, 12. Okay. And the balloon is nicely open. I don't like to provoke here a bit more.
Okay.
So it's nicely open. Now I have 16 atmospheres.
Perfect, yeah.
So I think we can make now maybe angio.
Yes, that's a good idea.
How it looks. And then we can start with stenting. We have long lesions, so we decided to use 2 stents, 3.0 distal leaf, 3.5.
Oh, great, it's a modified proximal.
You see, it looks completely
small dissection
different.
there. So
Okay.
maybe we go, Marek, with a 3.0 and go with 3.5 proximal then, one long one.
Then we can
So-
take
Or-
3.0, but 32 is too small.
38.
The question is which kind of stance should we take? Something which has really very good radial forces like Synergy, Megatron, or Onyx stance. So this will be our first choice.
Probably 3.0 Onyx here, and then go with 3.5 proximal for postultation. Huh?
So, but then we need 38.
Yes.
So we need, okay, we decide now to take Onyx 3.0, 38 millimeters, and we will go ahead proximal with 3.5 high pressure postulatation. And we have always option to check this in OCT. Onyx 3.8.
Yeah.
Just for me, another question regarding the LED. So you have to, we have now this slow flow phenomenon in the LED, which is almost almost closed. So do you think that has to be treated as well, or what is your rationale?
That's a big question actually from the beginning, because this guy had in 2012 2 attempts from a very good operator to open this, and there was a stent placed, and somehow he couldn't get anything through it, so he passed with the wire. So and he was relatively on stable angina. Then he came with a progression of angina, and then we saw the subtotal bifurcation on the RCA, and we did an FFR to the diagonal, and because we were not sure where is the so therefore we decided let's go for the RCA. Let's treat the proximal LED to the diac and see how the patient is doing before going more aggressively. Probably here, I don't know, maybe laser could be an option once I passed with a wire, or even rotor with a 2.5 spur. But we will rather split this. If we can treat him conservatively regarding distal LED, it would be okay for me, because 8 years and even the LV function was not going down, right? So it's so it's not a depression of the LV function; it's a good LV function, and yeah. So, and regarding prognostic with 80 years, I'm not sure if it has a huge benefit here. I'm not sure. So.
Tell us something about the deliverability of the stent. How does it feel after you have?
Very easy.
Open?
It's
very easy?
just straightforward. I just could go very easily inside. Okay, and you can go. Yeah.
Well, in this case, Candice and Marek, you have brought down the IVL balloon very easily. So in cases where you get stuck or you have some problems to deliver the balloon, do you use kinds of guide extensions, or what are your bailout maneuver to overcome this situation?
Yeah, first of all, if you see calcified lesions, I always would I would always recommend to you use it access support wire with access support quality. This is, I think, first.
Mit der 3.5er Ballon.
And
thank you.
And the next point will be, if this doesn't work, what you can do is to use guiding extension, and we use here Guideliner, Gatezilla, telescope, whatever.
Stent is drin, yeah.
And this will help you definitely to cross the lesion. Even last year I had such situation, a similar case, LAD, and I couldn't cross perfectly with IVL balloon. There was some resistance. So what I used for this crossing was Guideliner. 6 French Guideliner is compatible, so you can go very easy then without resistance to the culprit lesion and use IVL successfully. So this will be a point which can be definitely recommended. You can use this guiding extension even to place the stent in the position. Usually it's a longer stent. But in this situation, it was very easy.
Should we do one IC stent? Do you like to show one live stent? One. Yeah.
So we do now clear stand
Clear-
function and
okay,
without balloon.
Okay, perfect.
3 Sekunden. 1, 2, 3.
Okay.
Stop. So we do now a clear stand function to
just to show
you how the stand looks. I think there is
Jetzt
still. No.
Oh, it was the wrong button. I have to go
David?
to the right. Yeah, it's okay.
Oh.
It's okay.
3 Sekunden. Gestern.
Einen.
Das ist alles okay. Jetzt es funktioniert sehr gut. Okay, the point is we
It's
have
coming.
to take a look. Yeah.
Oh,
So you see there is still some.
Oh, it's good.
Not
Only this
yeah,
time we
yes,
can go
yes,
with
yes.
3-0 maybe.
Yeah, we could even go with a bit more higher pressure. You can go to.
Marek, there's another question coming up here from our audience.
Kann ich nochmal 3-0 haben für Distal?
The question is, you show us nicely
12.
the
Sapphire.
microfractures, disruption of the calcification.
Hochdruck.
And the question is, do we need also this kind of evidence by the OCT? And do we also need to ensure that there is this kind of fractures, or do you have other evidence that your IVL has worked?
Well, I think here it was clearly seen that the IVL worked also on the balloon, right? So we could really see that there was, especially in concentric calcification, I think it's straightforward. We have the duck bone, and if the duck bone is gone, the plaque is cracked, right? But in eccentric, it's a different story. So here I really like to have an idea about, could we modify plaque in a way? Did we have a disruption of calcification? So, so therefore, I really would go for imaging in eccentric calcification. And but also here, if the balloon is opening very nicely, the possibility or chance that you really have a good plaque modification is very high, right? So. But also for stent optimization, we know that the data are out that imaging has an impact on that. Yeah, you pushed a little bit. Okay, I'm good. Yeah, thanks. We still have
you are
minutes.
You are completely right. So we have seen, interestingly, the number of pulses were less in the eccentric in comparison to the concentric lesion in the sub-analysis, but nevertheless, we do not have the information in these kind of retrospective analysis of the OCT pictures. Well, I think as the balloon and the images are more has a more greater distance to the calcified plaque structure. The theory is that we need more pulses in eccentric than in concentric lesions. So just to explain that a little bit. So, well, this is a terrific result. What do you think?
Yeah, I think we will show you the OCT because we still should have 3 minutes. And if the OCT is okay, we make an angio shot and we're done. And with the case just in time, right?
So you see, we could improve result in proximal area. There is still minimal changes distally in distal part of the stent, but I use it now 22, 24 atmosphere. So we do now, I think, nice angio to show, first of all, yeah, it looks very nicely. And go now with OCT.
We have to check, Mark, the proximal part. I'm not sure if we need a stent proximal of the stent. Can you see there's some haziness?
Can we go to different projection? So we go to caudal and repeat this.
Yeah, I think that makes sense to have there. Please, maybe place the stent. Okay.
Okay, go.
Go, yeah. Looks good here. Maybe the spider. Oh, we'll see it in OCT anyway in a second. Oh, could be good, eh? Okay, all right.
He looks stable.
Okay.
Okay.
But this is a very nice result, even from the angiographic view. So of course we are interested in the OCT run.
Yes. Do we still have the time? I think so. It's only 2 minutes to go.
I think we take that time for the OCT. Okay. In the meanwhile, there's another final question coming from the audience: is which kind of coils did you use?
Yeah. Well, this was axiom coil. It was due to distal rotavar perf because I had to go a very long way down with with dynaclide in the lesion already, and to get the distal part rotablated, and fortunately got lost in a side branch with a wire. So axiom from EV3. And I mean, it's not a big deal to implant them, and it's a very big safety aspect. Okay, so anyway, we put some multiple millimeters of stent in, and so this little bit of metal, it's not a big deal for us. So we need some contrast media, and then we can show you the final OCT imaging. And yeah, wir sind bald fertig. And then we will follow up the patient clinically in the next 6 months regarding the LAD. If we need some LAD PCI there, the stent is endothelialized, and we can also go with a 1.125 rotabur down there. So I think this is not a big risk. Okay, so we are prepared, and
tell me when.
Okay, you can push, yeah.
Well,
okay, great.
Yeah. Just a question regarding the DAPT. So do you think that we have to extend the DAPT in this case?
I don't think so, actually. I mean, it's an 80-year-old guy. For sure, he has some risk of bleeding, and I think 6 months should be good for endothelialization. Yeah. So we see the final OCT. At least I can't see any big malposition there, but I think we have to repeat it maybe from the. Okay. Well, but minimal. This is, I think, acceptable here. Well, here we have still some eccentric plaque.
Well, yes, there are eccentric plaque structures. However, there are also some artifacts, I guess, in the of the run.
Sollen wir noch mal ein Run?
Proximal, we need definitely proximal to put one more stent, I think.
No, we will make another run, right?
Right. Okay.
So I will make another run, and in the meanwhile,
yes, I think we have to close here on the first stage, the case. And
we'll be back in 10 minutes. Yeah.
Yes, I will give a short overview about the CAD3 data, and after that, we will come back to your lab, and you can show us the final result of your case. Okay.
Ja, können wir noch einmal ein Run machen?
Okay. Thank you very much.
Thank you.
See you later.
Yeah. See you.
So now I'm happy to present you the results of the Disrupt CAD3 study. So the Disrupt CAD3 trial was a prospective multi-center single-arm global IDE trial, which was performed in the US, UK, Germany, and France. And the patient who are included in this trial had heavily calcified de novo coronary lesions with a reference vessel diameter from 2.5 to 4.0. And the definition of stenosis includes radiocapacity on both sides of the vessel, extending at least 15 millimeter by angiography, or a calcium angle at least 270 degrees by intravascular imaging. So every site had a roll-in patient. So that's in total there were 47 global sites. So we have a roll-in population of 47 patients, and there are intention to treat population of 384 patients. Note that there was an OCT sub-study of 100 patients. Well, the primary endpoint was assessed at 30 days follow-up, and there was a 100 patient OCT result of the OCT sub-study. The major endpoints was the freedom of maze at 30 days, and the maze was defined at cardiac death or myocardial infarction or target vessel revascularization. And there was a primary effectiveness endpoint of procedural success, meaning that it was a successful stent delivery with residual stenosis below 50% and without in-hospital maze. Well, there were some pre-specified performance goals, and these were based on the rates from the Medicaid single-arm non-randomized Orbit 2 ID study. And there was a primary safety performance goal of 84%, and this comes from the calculation of 100% minus 1.5 times observed 30-day maze rate in Orbit 2 of 10.4. And we had calculated also the performance goal of primary effectiveness of 38.4%. And this was calculated by 100% minus 1.5 times observed procedural failure rate in Orbit 2 of 11.1%. So these are the baseline characteristics. And as you can see nicely, there was a mean age of 71 years. 90% of patients had either hypertension or hyperlipidemia. 40% of patients had diabetes, and more than, on the right-hand side, you can see that more than 70% were in angina class 2 or more. These were the baseline angiographic characteristic with a reference vessel diameter of 3.0 millimeter. The minimal lumen diameter was 1.1. There was a diameter stenosis of 65%, and the average lesion length was 26%. And looking at the calcified length of 48 millimeters, and in all patients, severe calcification was confirmed. So these are the procedural characteristics showing total procedure time of 59 minutes. Predilation was necessary in 55%. In average, 1.2 IVL catheters were used with an average of 68 pulses per lesion. Post-IVL dilation was performed in 90%, sorry. Here you can see the angiographic outcomes, and on the left-hand side, you may appreciate the stepwise reduction of the diameter stenosis from baseline 65% after IVL of 37% and 11.9% after final stent implantation. On the right-hand side, you can see that there was a diameter, a stepwise increase of the minimal lumen diameter, and a diameter stenosis of less than 30% was achieved in 99% of the stenosis. These are the angiographic complications. As you can see, severe dissection directly post-IVL was seen in 2.1%, and after stent implantation, this could reduce to 0.3%. There was zero perforation, zero abrupt closure of the vessel, and zero no reflow in this registry. This is the primary effectiveness endpoint, which was observed in 92.4%, 2%. The lower confidence boundary of 89.9% meets the performance goal. And this is the prime effectus endpoint, which was observed in 92.4%. Again, the lower confidence boundary of 92% meets the performance goal at all. Well, these are the secondary endpoints of the device success rates, and as you can see nicely, there was a high rate of either device crossing success, angiographic success with a residual stenosis below 50%, and with a residual stenosis below 30%. And of course, we have this high composite success rate seen in these CAD3 registry. If you look at the peri-procedural eye using 3 definition, none of these definition was higher than 7%. And the right side, looking at the clinical endpoint at 30 days, there was a rather low event rate of TLF or revascularization and stent thrombosis. And IVL-induced ventricular capture has been noted in several cases or reports. In this study, it has been demonstrated that 41% had some evidence of ventricular capture, which was more pronounced in patients with a heart rate below 60 per minute in the very beginning. So this slide showing you the learning curve, and you are well aware of the fact that we have a learning curve in all kinds of new devices. This slide compares the 47 roll-in patient with which represents the first cases for each site in the study, and these were compared to the other patients, showing no difference in the key outcomes. That means freedom from MACE, procedural success, or device crossing success. So to conclude, Disrupt CAD3 trial success was achieved as both primary safety and effectiveness endpoints were met following treatment with coronary IVL in severely calcified lesions. The IVL prior to DS implantation was well tolerated with a low rate of major peri-procedural clinical and angiographic complications. And there was a transient IVL-induced ventricular capture, of course, but this was benign with no clinical sequelae in any patient. Although this study represents the initial coronary IVL experience for US operators, high procedural success and low angiographic complications were achieved, reflecting the relative ease of use of IVL technology. So with this, I like to switch over to Bud Krotzingen again and to have some final Q&A and closure remarks. And of course, you are very active in this webinar, and we have also some question left. And first of all, I like the operators to show us again the final results. Campus and Mark.
Yeah, Holger, can you hear us? Yeah?
Yes, yes.
Perfect. So you can already see the final result, the final stent result actually. And yeah, I will go one forward also in the other views. Here, very nice result. So we placed one stent proximal to the stent where we find some haziness, and we're quite happy with the result. And we want just to go back to the imaging to show you, because Dr. Löffel had already prepared us some very, very nice imaging models where you can see the plaque disruption actually from the IVL. It was really fantastic in this case, and you can see here the disrupted plaque at 10 o'clock and also at 2 o'clock. And this is great for lesion preparation there, right? So I think this is very impressive, and I have no idea how to modify this plaque in another way. So therefore, I think we did the best out of it. What we decided, actually, Marek and I, was we will follow up him clinically. And if the patient still has angina, we are going to put an IVL on the distal.
Können Sie switchen zum Bild, bitte?
Yes, we will. If the patient will have angina still, we will go to where the uptake of the LAD is, and then we will place another IVL there and try to modify the plug towards the LAD. But I think for 34 minutes today, it's too much. So we will decide to stop here at the moment. And yeah, we are ready for the questions and also for the discussion.
Thank you, Campus, for this terrific case, and it shows how experienced you are in these kind of calcified complex lesions, and they are always very difficult to tackle. And you guys managed that brilliant. So there are actually some questions from the audience, and I think the first question which we should discuss again, and we should make that very clear. What is your strategy to decide either IVL or rotational atherectomy? Which kind of strategy you have to go for the one or for the other device?
Yeah, first of all, Holger, the very clear answer. If you have subtotal concentric or eccentric calcified lesion, but with a channel below 2.0 millimeters. So you have to perform a kind of lesion preparation. So you need definitely 2.0 millimeter channel to come into the lesion with IVL catheter. So for that reason, either you go with a 2.0 non-compliant balloon, you go maybe up to 8 to 10 atmospheres, not to risk dissection. And if this doesn't work, it doesn't make sense to risk the crossing with IVL balloon, because other hands it's very delicate. It's just one membrane layer. You could damage the balloon, and yeah, then you need one more device. So then you have to think about different lesion preparation setting. Maybe you could go with rotablation 1.75 Burr or 2.0 Burr, and then on top of that with IVL. If you have option like we today, eccentric lesion, but we discussed this case. Here in this case, we could, I think, not really win a lot with rotablator. So we could maybe make some partial ablation of this eccentric plaque, but we will be never able to modify this calcified plaque like this way now just showed by OCT. I think if you have concentric lesion with area below, with diameter below 2, I think lesion preparation with balloon or rotablator is a first step. And if you have imaging, and if you have in imaging information, okay, there is enough lumen diameter, so even you could go directly with IVL catheter to the lesion and make and give shocks up. So
thank you, Marek. This makes it very clear. Just this brings us, but this brings us to the next question. What about bifurcations? So should we go directly upfront in bifurcation with the IVL, because we don't have this wire bias, and we don't have to exchange the wires?
Yeah, Holger, we do a lot of bifurcations, and
I know that.
Every day we have to treat bifurcation lesions, and the huge benefit regarding lesion preparation in calcified bifurcation lesions is the fact we can let the wire in the side branch in position, so we can go safely with IVL balloon to the main branch or whatever. The other wire can stay in position. If we rotablate, we have to remove side branch wire or main branch wire, and this is sometimes a critical point. So I think I know you plan a study with IVL in side branch and bifurcation lesions. So I think this is a very clever and important
yes,
study.
especially if you have often in the diagonal, you have often a very concentric duck boning and in the uptake. And I think if you have this already on the balloon with low atmospheres, I think this is really the good effect where we will see on IVL in this scenarios. But also back to the bifurcation, Mark, maybe I can add something. Is actually if you have lumen areas below 2.0 or 1.5, even rota makes sense. But in bigger bifurcations, bigger vessel, maybe upfront IVL in future will be even more indicated.
Yeah, the same topic is distal left main, which is usually really heavy calcified lesions, and there is some data from Dr. Escarnet with I think more than 20 patients now with clinical follow-up after IVL using and distal left main with very good results and 100% success, technical success. So I think
okay, guys, let us
options.
Let us address two other questions coming up here in the chat. So I think it's very important to talk about complication with the IVL balloon. So did you experience any complication with the balloon, and how safe is this kind of device in your opinion? And there was some case report just coming up recently where we had this ventricular capture situation with a ventricular fibrillation as a result of IVL use. And do you have experienced any other complications, or what do you think about the shock topics of ventricular capture?
Well, we have just to keep in mind that it is at least it's possible, but in all PCIs there can be ischemic events and there can be also, but this is a little bit different, right? And for sure, we have, like every cath lab, we have our defibrillator on place, but it's a very, very, very rare scenario. And so therefore, I think every cath lab is able to treat it immediately. Regarding other complications, the only thing is, but it's not a complication in my point of view, is that sometimes you even see not only disruption, but the disrupted plaque may also result in a dissection. In very calcified lesion, this is a good sign. It's not a bad sign, right? Because once you have a dissected calcified plaque, you know that the plaque is modified in a very good manner. And the rest, I have to tell you, the truth is that it's a very safe and efficient method compared to super high pressure balloons, especially in eccentric calcification. Because if we go here with super high pressure up to 40, 50 atmospheres, what will be happen is that the calcium plaque, the calcified area will still stay there, but the opposite wall may have even a perforation. So I think therefore we choose also this case to show that also eccentric calcification can be treated by IVL.
Yeah, so I personally never experienced this complications. One point, according to the ventricular tachycardia, I think you should take a look if take a look if patients are have bradycardia. I think this could be pulse below 60 could maybe play some role. So then you have
to get an effect in the T wave, maybe.
Well, this is perfect.
We never experienced this.
I think I want to confirm that this kind of ventricular capture is a very, very rare event, and of course this was now observed. But if you look at the data, and if I look to my own experience, so we did now more than 120 IVL procedures, and there were never a complication which were device related. So, well, guys, you did a tremendous job, and thank you very much for this very educative case. And I think we have learned a lot treating complex calcified lesions. So also, they are congratulations from the audience, and thank you very much again to Candice Mashayeki and Marek Ferenc for this very nice case, and thank to the whole cath lab team of the Heart Center in Bad Krotzingen And I think this was a very, very good demonstration for this kind of
Thank you very much,
lesions.
Holger.
Okay, thank you,
All
and
right.
take care.
It's
All
okay.
the best.
Yeah.
Bye-bye.
Take
Bye-bye.
care, and thank you, dear colleagues, dear friends. I think we learned a lot how to treat personalized,
Nico, danke.
very
Das hast du
calcified
super
lesions.
rausgekriegt.
We have many options to tackle calcified lesion. On the one hand, we have the debugging devices, including rotational atherectomy, but there is now an alternative coming up on the market with the IVL Shockwave catheter. And I think we have learned how is our strategy to use these kind of devices, and what is the stepwise use of these catheters. And I think the live case demonstrated very well how nice the results are after treating these kind of complex calcified lesions with the IVL catheter. So with this, I like to close this webinar, and I want to thank you again for your attendance, and I thank also the organizers, which is Shockwave Medical and Radcliffe Cardiology, and I want to thank you again, and stay healthy, and goodbye.